Hello, it's Dmitry again. Today we'll be going back to the Mehlman Medical Internal Medicine PDF, going back specifically into the Heme chapter. This will be a part two, potentially if either this video and another maybe, or maybe this video will just be 2 hours long. Not quite sure. I would assume this is going to be probably an hour long. I would assume my endurance is simply not that great, or if it is, I simply do not want to exercise that degree of endurance for such a video. Regardless, we'll have to see, or maybe I have to see, because you already know if you're doing a recording how long I recorded. So we'll see. So let us begin. Thrombotic disorders. Factor V laden. Just be aware that there is a condition called factor V laden, FVL, which means the patient will have elevated clots/DVTs. Normally, factor 5A and factors 8A are reversed to 5 and 8, the inactivated forms, by protein C. Protein S is a cofactor for protein C. In factor V laden, we have activated protein C resistance, which means that factor V is resistant to cleavage by protein C. Conditions such as prothrombin mutation and MTHFR are also cause elevation in clots, but are lower yield. Protein C deficiency causes clots/DVT, same as factor V laden, but is notably associated with skin necrosis if the patient receives warfarin. Antithrombin 3 deficiency. Antithrombin 3 is required to reverse 2A thrombin, which is the active form, right? Remember, A in this context means the activated form. So factor 2A thrombin, 10A and 9A back to an active 2, 10, and 9 presents two ways on USMLE. One, a young, otherwise healthy adult who has thromboses, plus the question mentions nothing about PT or PTT. Two, patient with nephrotic syndrome who has a DVT, superficial thrombophlebitis, renal vein thrombosis, or varicocele. Antithrombin 3 is a protein that can be lost in the urine. Antiphospholipid syndrome, APS. Antibodies against phospholipids that cause in vivo thromboses despite the paradoxical in vitro elevation in PTT. That is to say, if PTT is elevated, you'd think you'd have a bleeding diathesis, not thromboses. PTT is messed up because we need a phospholipids for in vitro assay to work. In vivo, we have thromboses, however, because 1. Antibodies against phospholipids in platelet membranes activate platelets and cause them to secrete procoagulant molecules. 2. These antibodies also bind to vascular endothelial cells, causing endothelial dysfunction and prothrombotic state. 3. The antibodies are pro-inflammatory, where elevation and activity of IL-6 and TNF-alpha activates tissue factor, factor 3. USMLE will not assess you on these three mechanisms. I merely write them here because this diagnosis is exceedingly high yield but remains perennially elusive and confusing as heck for students. Can be idiopathic, that is to say, caused by antibodies against beta-2 microglobulin or cardiolipin, or secondary to systemic lupus erythematosus. If APS, again that's antiphospholipid syndrome, is due to lupus, we merely call these antibodies lupus anticoagulant, but they are the same antibodies. For whatever magical reason, APS can cause false positive VDRL syphilis tests. High-yield neutropenia conditions. A high-yield general point for USMLE is that neutropenia can present as a mouth ulcers, fever, and sore throat. Questions will not usually come out and say, yes, the kid has neutropenia. The situation might be, that is to say, a kid who's undergoing chemotherapy for AML, acute myelogenous leukemia, who now has mouth ulcers and or a sore throat. Neutropenic fever, febrile neutropenia, neutropenia plus fever, LOL. Yeah, the name kind of gives it away what's going on. Can occur in the setting of a patient who has chemo or radiotherapy-induced pancytopenia, that is to say RBCs, white blood cells, and platelets are all decreased, or viral-induced neutropenia, that is to say parvovirus B19, where you see that the patient has fever and neutrophils are low, plus or minus RBCs and platelets. Medical emergency, that is to say the patient has infection but no ability to fight it. USMLE wants IV broad-spectrum antibiotics as the next best step. After antibiotics, the USMLE wants the granulocyte colony stimulating factor, that is to say GCSF or filgastrin, as the answer. I've never seen granulocyte transfusion as a correct answer on USMLE. Viral-induced neutropenia. Parvovirus B19 can infect myeloid precursors and cause neutropenia, that is to say viral-induced neutropenia. Other viruses can cause formation of antibodies against neutrophils, similar to how they can cause antibodies against platelets in ITP. Cyclic neutropenia. Gene mutation causing episodes of fever plus mouth ulcers in a kid who's aged 1 to 3. These episodes typically occur every 21 days, but the question might not specify this number, and you'll just have to say, there are several episodes like this before. Other anemias. Aplastic anemia means all cell lines, that is to say RBCs, white blood cells, platelets, are decreased. Can be due to parvovirus B19, where it infects not just myeloid progenitors causing neutropenia, but also erythroid progenitors and megakaryocytes, causing decrease in RBCs and platelets respectively. It can also be due to other viruses such as Hep A, CMS, PED5, or HIV, PEDS5 I should say, or HIV free 120, can be chemo and or radiotherapy induced. Fanconi anemia is rare, AR, autosomal, which means autosomal recessive aplastic anemia that, for whatever reason, it also presents with hypo/aplastic thumbs/radii. Pure RBC aplasia means only RBCs are decreased. It can be caused by parvovirus B19. Thymoma can cause pure RBC aplasia as well as myasthenia gravis. Diamond black fan anemia is rare pure RBC aplasia that presents with triphalangeal thumbs. Spherocytosis. Hereditary. Autosomal dominant, one of the highest yield inheritance patterns in USMLE, heterozygous mutations in ankyrin, spectrin, or band proteins causing an RBC cell membrane/cytoskeletal defect. This causes the RBC to deform away from the normal biconcave disc and into a spherical shape. The USMLE might give you a hereditary spherocytosis, and then the answer is just cell membrane or cytoskeleton or cytoskeletal defect. Can be described as RBCs lacking central pallor. If they show you a smear, they look full and red. There's a little picture right there for you. So these are hereditary spherocytosis. Okay, causes a normochromic anemia, as on NBME directly. Can be caused a pigment stone cholelithiasis due to the spleen identifying the spherocytes as abnormal and increasing RBC turnover. RBC mean corpuscular hemoglobin concentration (MCHC) can be elevated. This is not specific to spherocytosis, but is nevertheless a rare lab parameter to see on questions. It's to my observation that if they mention 4 out of 5 times the diagnosis is spherocytosis, diagnosed via osmotic fragility test and eosin 5 melamide. Coombs test is negative means we don't have antibodies against RBCs. This is important in terms of contrasting with spherocytoses due to the hemolysis that is, as I discussed below. Treatment is splenectomy to decrease RBC turnover. The answer can appear on USMLE as splenectomy and cholecystectomy together. USMLE can mention a child who has a low hemoglobin plus one of the parents had splenectomy plus or minus cholecystectomy performed in the past year for an anemia. The answer should be hereditary spherocytosis. I also point out to the student that the autosomal dominant inheritance pattern based on one of the parents having a condition as well. Question can also be straight up ask you which heme condition is often related with splenectomy. The answer is hereditary spherocytosis. Students sometimes erroneously choose sickle cell. Remember that sickle cell causes autosplenectomy due to the repeated microinfarcts with splenic microvasculature. It is not treated with splenectomy. And the reason they say it's functional splenectomy is because it basically autosplenectomy is because it basically renders the spleen unusable, dysfunctional. So that's why it's called autosplenectomy. It's actually rendering the spleen useless, essentially. Versus splenectomy is a treatment where you actually just remove the spleen yourself. You see what I'm saying? Hemolytic anemia. Spherocytosis is not always due to hereditary spherocytosis and can sometimes be seen with a drug or infection-induced hemolysis. In this case, the Coombs test is positive, meaning we have antibodies against RBCs. In contrast, with hereditary spherocytosis, the mechanism has nothing to do with antibodies, so Coombs test is negative. Antibodies binding to RBCs can trigger complement-mediated damage, which can lead to deformation of the RBC membrane and cytoskeleton. USMLE will give a kid with recent viral infection who has a low hemoglobin and spherocytosis on a smear, plus positive Coombs test. The answer should be hemolytic anemia, not hereditary spherocytosis. The answer is no specific mutation. Leukemoid reaction. Exaggerated immune response to infection in which the white blood cells go to significantly increase and can hence resemble leukemia. As I mentioned before, oid means looks like but is not, so the patient's labs can look like leukemia because the white blood cells are so high, but it's not leukemia. Normal leukocyte count is 4 to 11,000 microliters per microliter, I should say. Typical infections might cause white blood cells to go to the teens or 20,000s per microliter, but when the white blood cells creep into the 30s, this becomes increasingly rare, even for patients who are septic, so they want to start thinking about leukemia in that case. This is why the patient doesn't turn out to have leukemia. We call it leukemoid reaction, because it resembles leukemia, but is not. This will be the answer on USMLE for a patient who has an infection of white blood cells greater than 30,000 per microliter, plus they give you a blood smear that shows neutrophils, or they say leukocyte ALP is elevated in CML, it's low. This is the smear the USMLE will show you if they want leukemoid reaction. This is showing you neutrophilia, that is to say lots of neutrophils, and you can also write an answer as reactive granulocytosis or as increased release of leukocytes from the bone marrow post-mitotic reserve pool. A typical leukemoid reaction question might give you a UTI plus white blood cells at 32,000 per microliter as the above smear, not hard. I'm going to take a brief break. Okay, let us continue. High-yield leukemias. A leukemia is a cancer of white blood cells in the blood. They are almost always B-cell in origin. Apart from Sézary syndrome and mycosis fungoides discussed below, if one of the high-yield lymphocytic leukemias, that is to say ALL, CLL, is T-cell in origin, USMLE will give you SVC-like syndrome, that is to say positive Pemberton sign with congested neck, veins, and or facial erythema/swelling due to the thymic lesion. ALL, or acute lymphoblastic leukemia, the answer on USMLE for a kid with leukemia, that is to say pre-adolescent. Question will give you a kid who's, for example, 6 years old and has leukocyte count of 60,000 per microliter, where it's 90% lymphocytes. An important differential diagnosis of ALL is pertussis. That, for whatever reason, can cause an ALL-like picture where the white blood cells can be 30 to 40,000 plus, where it's 90% lymphocytes. This is called reactive lymphocytosis. The distinction for ALL is that pertussis, they'll say that there's a cough and or post-tussive emesis, vomiting after cough, and or hypoglycemia, high yield finding in pertussis. ALL can be CD10 and TDT positive, dumb, but I've received feedback of them showing up with an elevated risk of Down syndrome. The question can give you a standard vignette of Downs and then ask for what is the child's greater risk of developing. The answer should be excess lymphoblasts. So here's an ALL. Lymphoblasts appear smooth and relatively uniform. CLL, or chronic lymphocytic leukemia, vignette will sound just like ALL, but not in a kid, usually older adults. The question might say 70-year-old with white blood cells of 87,000 per microliter, 90% lymphocytes. Where they ask the next best step, the answer should be quantitative immunoglobulin assay, which can show an elevation of monoclonal immunoglobulin, sometimes in CLL. Sounds nitpicky, but it's an answer on the NBME. CLL smear can show smudge cells, which are fragile cells on LM. Leukemic cells are CD5 and CD23 positive, as on NBME, can be associated with the warm autoimmune hemolytic anemia, IgG, and RBCs. AML, acute myeloblastic leukemia, will show Auer rods on a smear. The image of the Auer rods is exceedingly high yield for the step. They are composed of myeloperoxidase, which is a blue-green heme-containing pigment. And if an AML question doesn't give you the buzzy images of Auer rods, they'll say it's 30% blasts or 50% blasts. See the Auer rods in there, little rod-shaped things in there? Acute promyelocytic leukemia, AML, aka AML, APL, aka AML type M3, has a T1517 translocation. Treatment is an all-trans retinoic acid, vitamin A. This is because causes the maturation of leukemic cells into mature granulocytes. Treatment of AML also leads to leukemic cell lysis, where release of Auer rods into the circulation can precipitate DIC. CML, chronic myelogenous leukemia, caused by T922 translocation Philadelphia chromosome, results in formation of BCR/ABL tyrosine oncogene tyrosine kinase, which is a fusion protein. The stem will say that there's all sorts of myelo-sounding cells, myelocytes, promyelocytes, metamyelocytes. 9 out of 10 questions will mention these cells are CML. Leukocyte ALP is low. Smear shows that I refer to as a motley mix or soup, which shows all different types of cells. This is high yield smear that differentiates it from leukomorph reaction, which instead shows neutrophilia. The treatment is with imatinib, which targets the BCR-ABL tyrosine kinase. Hairy cell. Question will merely say the patient has leukemia characterized by cytoplasmic projections that stains positive for tartrate-resistant acid phosphate, TRAP. The stem will give you low white blood cells, which is unusual for leukemia. 9 out of 10 questions for leukemia will give ultra-high yield white blood cells. The MBME question I've seen on hairy cell gives image similar to above, plus gives white blood cells. 3,500 plus, they say white blood cells of cytoplasmic projections, plus stains positive for TRAP. Sézary syndrome. Cutaneous T-cell lymphoma that extends to the blood as a T-cell leukemia caused by human T-cell lymphotropic virus, HTLV, has cerebriform shaped T-cells in bloodstream, presents classically as erythroderma, red skin. Lymphomas. A lymphoma is a cancer of the lymphatic system. Usually starts in lymph nodes, but it can also present in other areas of the lymphatic system, such as spleen and bone marrow. Almost always B-cell in origin. Lymphomas are categorized as Hodgkin or non-Hodgkin, NHL. Epstein-Barr virus, HIV, general immunosuppression, that is to say, chronic corticosteroids or immunosuppressant drugs, and autoimmune disease, that is to say, lupus, Hashimoto, increase the risk of thymomas. Hodgkin lymphoma, characterized by Reed-Sternberg cells, which are CD15/30 positive B cells with a characteristic owl eye appearance. Or plus B cells, I should say. Or is that positive? I'm not sure. I think they mean CD15/30 positive B cells, yeah. So anyway, Hodgkin's, let's continue Hodgkin's lymphoma. 100%, see that those cells right there, 100% of questions will give a painless lateral neck mass of facial swelling, lymphadenopathy. The USMLE question will give you give you at least one additional finding, such as 1, hepatomegaly, 2, mediastinal mass, not thymoma, this is a mediastinal lymphadenopathy. 3, virginal node, Toisier sign of malignancy, probable left supraclavicular lymph node. This is not limited to gastric cancers. I've seen on an NBME question where they give you this latter finding for Hodgkin, okay. B symptoms like fever, night sweats, weight loss are common but not mandatory in vignettes. Question can give normal leukocyte count and differential. An NBME question gives white blood cells of 10,000 per microliter. Normal range should be 4 to 11,000. And lymphocytes are of 33%, normal range 25 to 33. This is because lymphomas are cancers in lymphatic tissue. They're not leukemias, which are cancerous white blood cells floating around the blood. Nodular sclerosing type tends to favor women. Elevated normal B cells relative to abnormal RS cells, better prognosis. For example, leukocyte-rich Hodgkin has elevated normal B cells in comparison to the RS cells that are better prognosis. In contrast, leukocyte-deplete Hodgkin has comparatively more RS cells and worse prognosis. Burkitt lymphoma, that looks pretty nasty. T18 to 14 translocation of the c-Myc gene. It can rarely be a T2 to 8 or a T8 to 22. It's normally a T8 to 14. c-Myc is a transcription factor. Presents classically as a jaw lesion in an African boy or as a abdominal lesion. I always heard it as North African, which is genetically different thing than African, like as in sub-Saharan African. I don't know. Let me look at Burkitt lymphoma. Burkitt lymphoma it says here that it's endemic to equatorial Africa, not North Africa. Here's a little detour. When I was taking a course, they indicated that it was Burkitt lymphoma is characteristic of North African children. Well, North Africans are not the same thing as equatorial Africans. Pretty famously, that's not the same thing. So I guess I was taught wrong. Anyway, so histo is a buzzy starry sky appearance, which is a background of a basophilic purple B cells with translucent macrophages. Not to say that you can't find it in other places, it's just that probably there might be a gene that's associated with that in that particular region that's going to be at lower concentrations, potentially absent in some cases in other areas because of, limited gene spreading from other pools. Anyway, let's continue with Burkitt lymphoma, right? This is Burkitt lymphoma. So Burkitt lymphoma sounds odd, but NBME wants you to know that the macrophages are called tingible body macrophages, not tingible, which phagocytose the lymphematous B cells undergoing apoptosis. An NBME question points to a tingible body macrophage, and then the answer is just apoptosis. The macrophage itself isn't undergoing apoptosis, it's merely phagocytosing the apoptotic B cells characteristic of Burkitt lymphoma. You might say, if the B cells are undergoing apoptosis, then how is the cancer growing, spreading? The answer is that the rate of proliferation far exceeds that of the apoptosis. Okay. Follicular. T1418 translocation of the BCL2 gene, which codes for the anti-apoptotic molecule, most common indolent NHL, which means less aggressive, presents as a waxing or waning painless neck mass over the 1 to 2 years. DLBCL, diffuse large B-cell lymphoma, most commonly aggressive NHL. Mantle cell, this is a T11 to 14 translocation involving overexpression of the cyclin D, can't halt cell cycle. Mucous mycosis fungoides, cutaneous T-cell lymphoma characterized by cerebriform-shaped cells, less aggressive than the T-cell lymphoma of Sézary syndrome and does not extend to the blood as T-cell leukemia. An important differential for skin rash. And we are at 25. I'm just going to take another break. Just skip ahead if you're watching recording. Okay, I am back. So let's see. We're on page 167. Haha. And we will be finishing about 180. Let's begin again. Warm versus cold autoimmune hemolytic anemia, AIHA. Both present with positive Coombs test, which is just meaning antibodies against RBCs. In other words, if the question says Coombs is positive, we have antibodies against RBCs. If it's negative, we do not. In positive, we have antibodies against RBCs. If it's negative, we do not. Okay? Very important to be aware of. Warm, IgG antibodies against RBCs. Warm because agglutination of RBCs occurs at warmer temperatures. The stem can say agglutination occurs when the nurse holds the tube of blood by hand. Seen on USMLE for autoimmune diseases such as lupus or rheumatoid arthritis, CLL, or can be drug or infection induced. Cold, IgM antibodies against RBCs. Cold because agglutination of RBCs occurs at cooler temperatures. The stem can say agglutination occurs while the tubes are transported en route to the laboratory, seen on USMLE for mycoplasma pneumonia and CMV mononucleosis. Infectious mononucleosis, usually caused by Epstein-Barr virus, EBV, but they can also be caused by cytomegalovirus, CMV. The virus invades the B cells, which then stimulates the immune system to produce CD8 positive T cells attacking the viral infected B cells. In mono, these CD8 positive T cells are called atypical lymphocytes. The USMLE wants you to know that these are reactive CD8 positive T cells. They are reactive because they are responding to the viral infected B cells. Primary infection presents usually in teenager or young adult with a fever of greater than 38 Celsius. Lymphadenopathy, tonsillar exudate, and lack of cough, making the presentation appear bacterial in the high-yield pulmonary PDF. I talk about the CENTOR, CENTOR, criteria for differentiating bacteria from viral URTIs. As a result, it is often misdiagnosed as strep pharyngitis. If amoxicillin or penicillin is given to treat Epstein-Barr virus, this can cause a rash. This is not to be confused with a rash caused by allergy or to beta-lactams. If the pre-adolescent receives a beta-lactam and gets a rash, this is likely beta-lactam allergy. If a patient, adolescent, or older gets a rash, we do a heterophile antibody or monospot test as the next best step in diagnosis, as Epstein-Barr virus mono is more likely. Following the primary infection, mono can present as a recurrent episode of extreme fatigue that arise at interval separations of months to years. What about Langerhans cell histocytosis, or LCH? Overproduction of Langerhans cells, which are the dendritic cell of the skin. A dendritic cell is a strict antigen-presenting cell, APC, which phagocytosis antigen migrates to the lymph nodes and the spleen and presents it to CD4 positive T cells. Macrophages and B cells are also antigen-presenting cells, but they are not dendritic cells because they have additional functions. That is to say, macrophages destroy antigens, B cells mature into plasma cells and produce antibodies. The Langerhans cells that over-proliferate do so notably in bone, causing lytic lesions, that is to say, of the skull. Burbeck granules or tennis racket are rod-shaped inclusions within the Langerhans cells visualized on electron microscopy. Students remember that the granules are tennis racket shaped, but do not know the rod shape. There is an LCH question on NBME. Again, that's Langerhans cell histocytosis. Question on NBME where they give you a rod-shaped Burbeck granule. They give you the rod-shaped Burbeck granules, and the students are confused because they say, but wait, they're not tennis racket shaped though. Yeah, okay. So here's a tennis racket shaped Burbeck granule, and here's the rod-shaped Burbeck granule. Can I go back up? says the Langerhans cells that overproliferate due so notably in the bone causing lytic lesions, Burbeck granules or tennis racket or rod-shaped conclusions within Langerhans cells visualized on electron microscopy. Students remember the granules are tennis racket shape, but don't remember the rod shape. Okay, so there's like different versions of the shape basically. They include tennis racket or rod shape inclusion, so it could be either one of the two. So tennis racket shape or Burbeck granules, and then rod shape Burbeck granules. But both of them seem to be indications of LCH, of Langerhans cell histiocytosis. So there is difficult LCH and BME question floating around where they don't know the Burbeck granules at all and just show you the abnormal Langerhans cells straight up, and they tell you a kid has a lytic lesion on his skull, and they show you an image of something, show you something similar to the following, like that. You say, no idea what I'm looking at, agreed, but it's on the NBME. Apparently the Langerhans cells in LCH appear as large, irregularly shaped cells with copious eosinophilic cytoplasm and characteristic horseshoe or kidney-shaped nuclei. Because there's so many pictures in this one so far, we're making decent progress because there's less words on the page. We're on 169 right now, and we're only 37 minutes in, so... Acanthocytes, spur cells, spiky RBCs that show up notably in the liver failure due to heat stroke. I've probably only seen around 4 questions with acanthocytes on NBME material ever. 3 out of 4 are liver failure. 1 out of 4 is A beta lipoproteinemia. Other resources get the yieldness reversed, where they mention A beta lipoproteinemia as though it's this high yield association. Nonsense. USMLE cares about liver failure. Heat stroke is an end organ damage due to the hyperthermia greater than 104 degrees Fahrenheit. Heat exhaustion is more fatigue with no end organ damage due to hyperthermia. Heat stroke presents on questions as abnormal liver and or renal function tests. Question will say an old lady found in her house in the summer has body temperature of 106 degrees Fahrenheit and acanthocytes on a blood smear. What's the diagnosis? The answer should be liver failure due to heat strokes. Another NBME question gives hepatitis C with acanthocytes. The latter are not critical to answer the question, but I noted that the NBME mentioned them for hepatitis, that is to say, not heat stroke. Not just heat stroke, I should say. G6PD plus PK deficiencies. G6PD deficiency. Glucose 6-phosphate dehydrogenase deficiency, or X-linked recessive, most common cause of hemolysis due to the enzyme deficiency, presents as a hemolysis and jaundice in a boy who recently received a drug or had a viral infection. High-yield agents can precipitate oxidative damage of RBCs in G6PD are primaquine, dapsone, and sulfa drugs, and favobeans. Vignette might be a 12-year-old boy with scleral icterus following a viral infection. Labs might show increased unconjugated hyperbilirubinemia and LDH due to hemolysis. RBCs are packed with LDH. High LDH can be USMLE's way of saying there is hemolysis. G6PD is an enzyme necessary to produce NADPH, which is a reducing agent that protects RBC membranes from oxidative damage. Bite cells that in Heinz bodies are buzzy and high yield. Bite cells are RBCs with bite-like notches caused by oxidative damage. Heinz bodies are clumps of oxidized/denatured hemoglobin. So those are bite cells, and those are Heinz bodies. So it's your pyruvate kinase, second most common cause of hemolysis due to an enzyme deficiency, leads to a decrease in ATP production. This leads to a decrease in activity of the RBC, sodium-potassium ATPase pumps, which leads to a decrease in potassium being pumped out of the RBC. This leads to water stays within this, with sodium, and therefore cellular swelling plus lysis. I'm going to take a break here, I think. Yeah, sure, fine. Okay, let us continue. Macrocytic causes. Macrocytosis causes. Okay. Normal RBC mean corpuscular volume MCV is 80 to 100 femtoliters. Macrocytosis refers to large RBCs greater than 100 femtoliters. B9 folate/B12 deficiencies. Deficiencies of either vitamins leads to impaired DNA synthesis, where the RBCs remain in the bones for a longer period of time, leading to RBCs that are larger and less mature. High MCV as a result of the impaired DNA synthesis is called megaloblastic anemia. Impaired DNA synthesis also causes hypersegmented neutrophils, where a longer time spent in the bone marrow results in an increased number of nuclear lobes and segments. So there we go right there. What about alcohol? Alcohol, an important cause of high MCV unUSMLE in the setting of normal B9 and B12 levels. Alcohol can also cause other types of anemia like sideroblastic anemia. What about erotic aciduria? Obscure condition where the DNA synthesis gets impaired, leading to increase in MCV, can be caused by various enzyme deficiencies. Maybe shows up in NBME question in all of history. You could just peripherally be aware it's as rare as heck cause of high MCV. Leflunomide, an obscuring drug used for rheumatoid arthritis, inhibits dehydroorotate dehydrogenase, one of the enzymes that are deficient in erotic aciduria. So here's heme synthesis plus disorders. Succinyl-CoA plus glycine. Yeah, this inhibition is that high yield starting molecules? Okay, and that via B6 and delta ala deaminase. B6 and delta ala synthase help convert the succinyl-CoA into glycine into delta ala, and then ala dehydratase converts it into porphobilinogen, and then porphobilinogen converts it via porphobilinogen deaminase into hydroxymethylbilane, and that's converted into uroporphyrin 3. And then via uroporphyrin decarboxylase, that's converted into coproporphyrin 3, which is then converted into protoporphyrin, which is then converted via ferrochelatase into heme, using iron. And when these things, lead poisoning messes with ferrochelatase and aldehydrate. Acute intermittent porphyria messes with porphobilinogen deaminase, and porphyria cutanea tarda messes with uroporphyrinogen decarboxylase. I have my own diagram that has a lot of the same material. It's not drawn in the same way, though. But pretty similar. Heme synthesis disorders. Sideroblastic anemia. Impaired first step of heme synthesis, that is to say succinyl-CoA plus glycine via B6 and delta ala synthase to delta ala, due to the deficiency or impairment of delta ala synthase, can be X-linked recessive, but also can be caused by alcohol. Failure to incorporate iron into heme, this leads to ringed sideroblasts, which are erythroblasts, RBC precursors, where the iron accumulates inside the mitochondria, where the latter form a kind of ring around the nucleus. The iron-laden macrophages stain blue with Prussian blue stain, making it very buzzy in pass-level image for USMLE. So you can see that looks like Prussian blue hanging around there and giving, I would assume that's a ring appearance is what they're trying to get at. I'm not 100% on that part. But yeah, definitely you can see the Prussian blue in those cells. Okay. But you can see the Prussian blue there, I think. Lead poisoning. USMLE wants you to know that the lead inhibits both the delta ala dehydratase and ferrochelatase, results in buildup of delta ala. The stereotypical vignette of a 2-year-old eating paint chips in an old house leading to mental deterioration is too easy and maybe only 1/3 of lead questions. The other 2/3 will be an adult who has macrocytic anemia and mental decline. Buzzy hobbies can be hunting, bullets containing lead, or home brewing of alcohol, cask made of lead. Can cause basophilic stippling of RBCs, rRNA precipitates. Treatment would be calcium EDTA, dimercaprol, or succinylcholine. AIP, acute intermittent porphyria, autosomal dominant, sounds low yield, but asked straight up on an offline MBME somewhere. Okay. Caused by deficiency or of porphorinolidine deaminase, asked on NBME, causes buildup of porphorinolidine and delta ALA. Asked on USMLE for the heme synthesis disorder where the patient has red/pink or /port wine stained urine, colored urine, and abdominal pain. Patients can sometimes have miscellaneous neurologic findings, but not mandatory. Treatment is hematin and glucose. And for reference, acute intermittent porphyria, as a little fun fact for you, is the disease that they think the King of England had at the time, King George the whatever, who was the King of England at the time, or Britain, you could say, more broadly speaking, during the war between the United States and Britain, during the Independence War. Proximal convoluted tubule, wrong PCT. Porphyria cutanea tarda, caused by deficiency of uroporphyrinogene decarboxylase, leading to increased urinary uroporphyrins. Answer on USMLE for the heme synthesis disorder where the patient has photosensitivity/blistering. Urine can have a tea-colored/dark. Don't confuse with the red-pink port wine urine and AIP. So, for AIP, think about the King of England, and he has this sort of port wine, weird colored urine, and some neurological issues potentially, and that's related to a porphorinolidine deaminase deficiency, and there's a buildup of these other kinds of toxic things like porphorinolidine and delta ALA. Well, the porphyria cutanea tarda, see, porphyria starts with P. They're photosensitive, right? It's almost like a vampire situation, not exactly, but they have blistering and photosensitivity, and they have an increased. Let me see. What do they say? Leading to increased urinary uroporphyrins. Yeah, instead of dark urine or tea-colored urine. So you can think about you could think of a vampire drinking tea, and I guess you could think about the King of England having some wine or something like that, I guess. You'd think it'd be the king drinking some tea, but it's a little bit different situation. Yeah, think about for PCT, think tea-colored urine, and for AIP, think about port wine-colored urine. And again, for PCT, it would be porphorinogene decarboxylase deficiency. What about intra versus extravascular hemolysis? Well, intravascular hemolysis, lysis of RBCs within the bloodstream, causes a release of bilirubin directly into the blood, leading to hemoglobinuria. Serum haptoglobin is decreased. Haptoglobin is a protein produced by the liver that binds to and removes the free hemoglobin released from the damaged or lysed RBCs. This mopping up of the hemoglobin by haptoglobin prevents the renal damage and helps to recycle iron. Low serum haptoglobin levels can be used to differentiate from extravascular hemolysis. A few high-yield examples of intravascular hemolysis are A. G6PD deficiency, oxidative damage to RBCs. 2. PNH due to the complement-mediated hemolysis. What is PNH? I want to say paroxysmal nocturnal something. Paroxysmal nocturnal hemoglobinuria. Okay. So, where are we? Oh, yeah. PNH due to a complement-mediated hemolysis. HUS, hemolytic uremic syndrome. TTP. Is that like thrombotic thrombocytopenic purpura? And a HELP syndrome. DIC. Disseminated intravascular coagulation. Mechanical hemolysis or prosthetic valves due to sharing of the RBCs, all schistocytes. Extravascular, phagocytosis and lysis of RBCs within the spleen and also liver. Hemoglobin from lysed RBCs is not released directly into the bloodstream. It is broken down within macrophages, forming biliverdin, which is converted into bilirubin. Bilirubin then goes to the liver for excretion in bile. There is no hemoglobinuria. Haptoglobin is not decreased. The high-yield example are hereditary spherocytosis, a normal shape leads to the clearance by spleen. 2. Thalassemias. Imbalanced hemoglobin chains lead to RBC structural imbalance, which is recognized by the spleen as defective RBCs. 3. Warm and cold AIHA, where the antibodies opsonize RBCs, leading to the removal in the red pulp of the spleen. This could be noted that antibodies in AIHA can also lead to intravascular hemolysis if the complement is recruited, but most destruction of RBCs in AIHA is intravascular. Is that autoimmune hemolytic anemia? I think so. Yeah, well, it says autoimmune hemolytic anemia. Yes, I'm correct. Okay. Thalassemias and hereditary spherocytosis are extravascular, and also the AIHA. Okay. Hemolytic diseases of newborn types. Rhesus type, Rh type. 85% of people who have Rh antigen on RBCs, i.e. Rh positive, women who are in the 15% that are Rh negative are at risk of developing IgG antibodies against Rh antigen if the fetus is Rh positive and the circulation mix inadvertently. When the mother develops antibodies against Rh, that is to say has become sensitized to it, we call that Rh isoimmunization. NBME will throw this word around a bit, so you need to know what it means. She's developed IgG antibodies against Rh. Mechanism: Rh negative mom is first pregnancy is exposed to fetal blood that is Rh positive. Mother makes antibodies against Rh. Subsequent pregnancy results in IgG against Rh crossing the placenta and targeting the fetal Rh positive RBCs, leading to hemolysis in the fetus. As mentioned earlier, Rh status is checked at the first antenatal screening at 8 to 10 weeks. If the mother is Rh negative, then give the RhoGAM at 28 weeks as well as at parturition. It must also be given if there are any interventions, that is to say amniocentesis, or if there's complications like spontaneous abortion or abruptio placentae. If the second pregnancy onward, if Rh negative woman is found to have titers against Rh, do not give RhoGAM during the pregnancy since it's too late. Kleihauer-Betke KB test is done in the setting of hemorrhage or suspected mixing of maternal and fetal circulation in the Rh negative women. The mother's blood is drawn, and the test works by exploiting the resistance of the HbF, fetal hemoglobin to acid, allowing fetal RBCs to be distinguished from the maternal cells in a blood smear. Depending on the fraction of the fetal RBCs present, this determines the dose of RhoGAM necessary. Another 2CK question gives elevated fetal heart rate in third trimester in women who is in their second pregnancy who has positive anti-D titers. They ask the reason why fetal heart rate is elevated, and the answer is Rh isoimmunization, leading to destruction of fetal RBCs, which causes a decrease in oxygen delivery within the fetal circulation, which elevates the heart rate to compensate for that problem. ABO type. Most anti-A and B antibodies people have to opposing blood types are IgM, but people who with O blood can have fractionally greater IgG. If the mother with O blood has higher percentage of anti-A and B antibodies that are IgG, fetus can be symptomatic. USMLE will give you an O positive mother, usually in first pregnancy, and an A or B fetus can occur in Rh negative women in second pregnancies, but the USMLE wants you to assess you specifically to know the ABO type of HDN, so they'll give you an O positive mother in the first pregnancy. Okay. Kel, Duff, and just for reference, ABO, O is has neither antigen on it, while A obviously has A antigen and B has B antigen on it. And so the O mother would not recognize either antigen if they had a child who was AO or BO or whatever, and therefore have A or B antigens. Kel, Duffy, and kid type. Minor antigens beyond the Rh, i.e. Kel, Duffy, kid, can sometimes cause HDN. I want to make sure I'm saying this. HDN referring specifically to hemolytic disease of newborn. Okay, the process of isoimmunization is the same as Rh. What will happen is that an A positive, B positive, or AB positive mother will have a second pregnancy where the fetal hemolysis is occurring, but based on her blood type, you know it's not ABO or Rh type HDN. The question will say her blood titer, for example, Kel is high. The next best step is to check Kel status of the father. In other words, since the mother has titers against Kel, you know she's Kel negative, so the father's RBCs are Kel positive, the fetus is likely Kel positive, and that would explain the HDN. I'm going to take another break. Transfusion reactions. Febrile non-hemolytic transfusion reaction, FNHTR, caused by activation of donor white blood cells when they come into contact with antibodies in the recipient's plasma. This interaction triggers the release of cytokines from the donor white blood cells. These cytokines then cause symptoms of fever and chills. Coombs' test is negative since the process doesn't involve antibodies against donor RBCs. A positive Coombs test means that there are antibodies against RBCs. The vignette will be someone who gets a blood transfusion and then within 2 hours gets fever and chills. They will then ask for the mechanism as the answer. I've seen them write it off one of two ways. 1. Preformed antibodies against donor leukocyte antigens, and 2. Cytokine release from the transfused blood. Leukoreduction, a process that removes or reduces the number of white blood cells from blood components before transfusion, can be used to mitigate risk of FNHTR, again that's the febrile non-hemolytic transfusion reaction, by reducing probability of donor white blood cells coming into contact with recipient antibodies. Hemolytic ABO mismatch, caused by recipient antibodies against A and or B antigens on donor RBCs. This causes RBC agglutination and intravascular hemolysis, causing the release of hemoglobin into the bloodstream. Binding recipient antibodies to donor RBCs can also lead to complement activation and lysis of RBCs. LDH can be increased in setting of hemolysis. RBCs are packed with LDH. The vignette will be someone who gets fever, chills, often flank pain within minutes of blood transfusion. Vignette says, 10 minutes after a transfusion is started, the patient feels an impending sense of doom and the transfusion is stopped. Sounds like MI, but MBME writes this. They then ask for the next step, which is an antiglobulin test, another way of saying Coombs test. So keep that in mind for how they phrase things. It might not be so straightforward. Delayed transfusion reaction, caused by recipient antibodies against minor antigens on donor RBCs, such as the RH, Kel, Duffy, or KID. Coombs test is positive. Vignette will be someone who has surgery plus received RBCs intraoperatively. Over the course of a week following the surgery, hemoglobin gradually decreases. The answer is then Coombs positive, unconjugated bilirubin as a combination that would be seen. So Coombs, unconjugated bilirubin, okay. Transfusion-associated lung injury, TRALI, T-R-A-L-I. The answer on USMLE if the patient has an ARDS-like presentation with bilateral crackles and low O2 SATs less than 6 hours following a transfusion. Mechanism is abnormal priming of neutrophils in the lung that react to the cytokines within transfused blood products. This is straight from a CMS form, technically a type of non-cardiogenic pulmonary edema. Okay. Transfusion-associated circulatory overload, or TACO, aka transfusion-induced hypervolemia, differs from TRALI in that this is type of cardiogenic pulmonary edema, i.e. the left heart cannot handle the elevated hydrostatic pressure from the increased volume, so transudation into the alveoli occurs. The answer on the USMLE if the patient has an ARDS-like presentation greater than 6 hours following the transfusion, or gets an ARDS-like presentation following transfusion in the setting of a cardiovascular disease, in other words, presents one of two ways. They don't mention the history of cardiovascular disease, plus the vignette will sound exactly like TRALI, greater than 6 hours following a transfusion. 2CK form gives an elderly dude who received only 3 packs of RBCs plus he develops a bilateral crackles and low O2 saturation, but they say this occurs 12 hours after admission, not less than 6 hours as with TRALI, where the answer is X-ray of the chest as the next best step in the diagnosis. The question doesn't rely on you discerning TACO versus TRALI to get it right, but the explanation says it's TACO. 2. If a patient with a history of heart failure or MI develops respiratory distress following transfusion of repeated blood products, a 2CK NBME question gives a 72-year-old with a history of MI 10 years ago who gets shortness of breath and bilateral crackles 30 minutes after transfusion with crystalloid solution and 4 packs of RBCs. They don't specify the volume of crystalloid in the question. In summary, if the ARDS-like picture after transfusion, if less than 6 hours, TRALI. If greater than 6 hours, TACO. If heart disease, then TACO regardless of time frame. Again, TRALI would be transfusion-associated lung injury, and then TACO is transfusion-associated circulatory overload. Heme, onc, farm, points of IM. So this is the final wrap-up section. So we're on page 176. We wrap up, I think, on 180 is the last page, if my memory serves correctly. Oh, no, I'm wrong. We're finished on 179. Full page, too. So heme, onc, farm, points for internal medicine. Aspirin, irreversible cyclooxygenase COX-1 and 2 inhibitor, non-steroidal anti-inflammatory drug, NSAID, aka salicylic acid salicylate, blocks the synthesis of prostaglandins and platelet thromboxane A2. Decrease in prostaglandin means a decrease in inflammation, pain, and body temperature. Decrease in thromboxane A2 means decrease in platelet clumping. Many high-yield use cases on USMLE. AFib with low CHADS2 score means i.e. congestive heart failure, hypertension, greater than age 75, diabetes, stroke, TIA, history of emboli, with the S being worth 2 points. If the 0 or 1 points, give aspirin to AF patient. If 2+ points, give warfarin. Okay. USMLE does not obsess over valvular versus non-valvular AF in terms of giving warfarin versus NOACs, NOACs. That is to say, dabigatran or apixaban, they will give you a aspirin or warfarin as the answer choices. Peripheral vascular disease and carotid stenosis means USMLE wants a triad of antiplatelet therapy, aspirin alone sufficient on USMLE, statin, and ACE inhibitors are A or B. Ischemic heart disease, i.e. patient who have angina pectoris, what you do is nitrates are used for acute angina, but daily aspirin is also given for these patients. Ischemic strokes after 4.5 hours has transpired. If less than 4.5 hours, give TPA. Aspirin can cause GI bleeds with a decrease in prostaglandins and a decrease in gastric mucosal barrier mucosis, mucus production, and protection. Nephropathy, pre-renal interstitial nephropathy, nephrogenic diabetes insipidus, asthma. Inhibition of COX causes shunting of the arachidonic acid down the lipoxygenase pathway, leading to leukotriene synthesis and bronchoconstriction. Never give aspirin to children due to Rye syndrome risk, defect in beta oxidation with cerebral edema and hepatitis. Misoprostol is given to patients following a PPIs if they have NSAID-induced gastric ulcers, Misoprostol is PGE1 analog, can cause high anion gap mixed metabolic acidosis, respiratory alkalosis, 5 in the S in mud piles. What about other NSAIDs? Other NSAIDs, reversible COX inhibitors, in contrast to aspirin, irreversible, indomethacin, used for acute gout and pericarditis. Ibuprofen, general NSAID used broadly for pain, fever, and autoimmune diseases, for like rheumatoid arthritis, IBD, lupus, etc. Naproxen, USMLE, favorite drug for causing GI bleeds and nephropathy, shows up on 2CK forums a lot. Diclofenac, ketorolac, just know these names for NSAIDs. 5-ASA compounds, mesalamine, sulfasalazine, used for IBD. What about acetaminophen? Well, this is a central acting COX inhibitor, not considered an NSAID because it doesn't act peripherally, decreases pain and fever, but is not an anti-inflammatory in the periphery. First-line medication for osteoarthritis, weight loss first treatment for osteoarthritis, but this is the first-line medication. NSAIDs not ideal first line because they kill the kidneys, plus OA is non-inflammatory, so NSAIDs don't provide added benefit over acetaminophen. Patients with chronic pain who take NSAIDs frequently are at risk for nephropathy and GI bleeds. Metabolite NAPQI causes massive hepatotoxicity. Activated charcoal can give immediately after consumption. Otherwise, N-acetylcysteine history as treatment. Latter regenerates the reduced glutathione, which neutralizes the NAPQI. What about celecoxib? Selective COX-2 inhibitor that does not cause GI bleed, still can cause nephropathy. NBME asks why celecoxib can increase the risk of MI. The answer should be decreases the prostaglandin production without inhibiting the platelets. Can in theory be used for pain and inflammation. Clopidogrel, antiplatelet agent, inhibits the ADP-P2Y12 inhibitor on platelets. MOA is high yield. Can be used to fulfill the antiplatelet component of the peripheral vascular disease and carotid stenosis triad, as mentioned before. 1. Antiplatelet therapy. 2. Statin. And 3. ACE inhibitor or A or B. In theory, can be used for stenting procedures, but I haven't seen USMLE care. It's more than this use case is perpetuated in resources. Can also be used in patients with ischemic heart disease who cannot tolerate aspirin. Prasugrel, ticlopidine, and ticagrelor drugs with same MOA but not assessed. Dipyrimidol, phosphodiesterase 3 inhibitor, prevents breakdown of cyclic AMP, causes arteriolar dilation, plus also an antiplatelet agent. USMLE really likes this. That is to say, they will ask, which of the following is both a vasodilator and an antiplatelet agent? Answer, dipyrimidol or cilostazol, whichever is listed. Dipyrimidol/thallium is a combination used frequently for pharmacologic stress testing. Arteriolar vasodilation causes heart rate to go up, where the thallium uptake into the myocardium can help visualize areas of ischemia. Cilostazol, phosphodiesterase 3 inhibitor, prevents breakdown of cyclic AMP, causes arteriolar dilation, plus also an antiplatelet agent, same as dipyrimidol, used for intermittent claudication / peripheral vascular disease after a walking / exercise program is already prescribed. Do not choose cilostazol as the first treatment for peripheral vascular disease. Choose walking / exercising program first. Then, if they force you to choose a drug from additional management, choose cilostazol. So if you have intermittent claudication or peripheral vascular disease, go for exercise walking program first, but then if you need to choose a drug, do cilostazol. Abciximab, GP2B/3A inhibitor on platelets, prevents platelet aggregation, that is to say platelet-platelet interaction. Do not confuse with GP1B. Do not confuse it with that, which is for platelet adhesion. Von Willebrand factor normally bridges GP1B on platelets of vascular endothelium / underlying collagen and is unrelated. Since physiologically, fibrinogen is normally what bridges the GP2B3A on adjacent platelets, abciximab is considered to be a fibrinogen analog. Drugs such as tirofiban and eptifibatide have the same MOA but are not assessed. TPA, alteplase tryptokinase. Tissue plasminogen activator activates plasminogen, which breaks down fibrin clots. I've only seen this used twice on NBME forms, one for ischemic strokes within 4.5 hours, and two for pulmonary embolism where there is obstructive shock, i.e. pulmonary embolism with lower blood pressure. Heparin activates antithrombin 3, leading to inactivation of thrombin factor 2 and factors 9A, 10A, 11A, and 12A. Use a bridging agent to warfarin when the patient needs anticoagulation. This is because warfarin, by inhibiting the protein C as part of its function, temporarily makes the patient hypercoagulable, causes both an elevation in PT and APTT. But APTT is used to monitor heparin over PT because APTT is more accurate / sensitive to the effects of heparin. This is because heparin inhibits intrinsic pathway factors, i.e. 9A, 11A, and 12A, in addition to the common pathway of factors, that is to say thrombin and 10A. In other words, 5 clotting factors within the intrinsic pathway are affected by heparin, but only 2 within the extrinsic pathway are, that is to say the common pathway ones. Subcutaneous enoxaparin, or low molecular weight heparin, used first line for DVT and superficial thrombophlebitis. Heparin is also used for acute limb ischemia and vertebral artery dissection. Clot can form within the false lumen, as on 2CK NBME. USMLE won't ask about unfractionated heparin versus low molecular weight heparin, but apparently unfractionated heparin is used in patients with 1, severe renal impairment, and 2, in those who might need rapid reversal due to uncertainty about dosing. In other words, unfractionated heparin can be reversed with protamine sulfate much faster than low molecular weight heparin. Heparin-induced thrombocytopenia, HIT, is exceedingly high yield for USMLE. Mechanism is autoantibodies against heparin platelet factor 4, PF4 complex, where the administration can lead to a decrease in platelets. This is a type 2 hypersensitivity reaction. Platelets are cells. NBMEs can write the answer simply as antiplatelet antibodies. Treatment is cessation of heparin plus give direct thrombin inhibitor, for example, dabigatran. Warfarin is the wrong answer, so don't go for warfarin. A 2CK NBME question simply has a direct thrombin inhibitor as the answer without listing the specific drug name. So they might just straight up tell you, oh, direct thrombin inhibitor. They won't go more specific than that. Warfarin dicumarol. Vitamin K epoxide reductase inhibitors, which prevents vitamin K from being recycled back to its active form. Vitamin K normally is a cofactor for an enzyme called gamma-glutamyl carboxylase, which activates the clotting factors 2, prothrombin, 7, 9, and 10. 2, 7, 9, and 10, as well as anti-clotting proteins C and S. Remember, 2, 7, 9, 10, and C and S. PT is used for monitoring over PTT because many of the intrinsic pathways clotting factors PTT are unaffected by warfarin, whereas most of the extrinsic pathway clotting factors PT are affected by warfarin. So basically, how do you monitor heparin, PTT? How do you monitor warfarin, PT? So the way that I remember it is from the sketchy sketch where they have the sketchy video. This is the first sketchy video I think I ever saw in my entire life, I believe, where they have a woodpecker that's tapping on a tree and it's making a PTTTTT sign on it, and that's for the heparin. These heparin hunters. This is really off. This seems like a digression, but whatever. And so I remember that the woodpecker making the PTTTT is that PTT is for heparin for monitoring, while PT is for warfarin for monitoring. Okay? International Normalized Ratio, INR, is the ratio of the patient's PT to a control standard PT, where the 2.0 to 3.0 is the usual target range for warfarin. Highest yield use cases on USMLE as for maintenance anticoagulation therapy in patients who have a DVT, prosthetic valves, or AFib with elevated CHADS2 score. As discussed earlier, heparin must be used as a bridging agent initially with warfarin because warfarin's inhibition of protein C, which has a very short half-life, makes the drug initially procoagulable. Warfarin levels are sensitive to drugs that inhibit or stimulate P450, for example. P450 inhibitors can significantly elevate INR and cause bleeding diathesis. P450 inducers can decrease INR and cause thromboses. As discussed earlier, vitamin K deficiency due to a broad-spectrum antibiotic causing depletion of bowel normal flora can increase INR, i.e. decreased warfarin is required to inhibit clotting, but we haven't changed doses. Teratogenic must be avoided in pregnancy. Warfarin is a small lipophilic molecule that readily crosses the placenta. In contrast, heparin is a large acidic polymer that does not cross the placenta. Warfarin can cause bleeding, diathesis, and bone abnormalities in fetus. So heparin is in theory okay to take during pregnancy. Warfarin is teratogenic. Do not go for that during pregnancy. Can cause skin necrosis in patients with protein C deficiency. Slowly reversed with vitamin K. Requires resynthesis of clotting factors by the liver. Quickly reversed by fresh frozen plasma. Supplies clotting factors. Dabigatran, direct thrombin inhibitor, used for HIT. So that's like what's going on in heparin-induced thrombocytopenia. Sometimes in the patients with non-valvular AF, AF as in AFib, with high CHADS2 score. I'm not quite sure what that means in that context, but AF. Apixaban, factor 10A inhibitor, just no MOA, mechanism of action. USMLE doesn't assess use cases, but given for a non-valvular AF with high CHADS2 score. Am I out of bounds on that one? What does the AF mean in this context? We're talking about, I don't know. What about fondaparinux? Factor 10A, just no MOA. USMLE doesn't assess use cases, but be given for DVT and P in cases of heparin in some patients, in place of heparin in some patients, as an alternative. Fondaparinux. Irinotecan and topotecan, topoisomerase 1 inhibitors. Etoposide, tenipicide, eukaryotic topoisomerase 2 inhibitors, anti-cancer agents. Do not confuse with prokaryotic topoisomerase 2 DNA gyrase inhibitors, which refer to fluoroquinolones, i.e. ciprofloxacin, levofloxacin. As far as I'm aware of, topotecan and irinotecan are also these sort of anti-growth cancer drugs things. So now we're talking about cancer drugs. So irinotecan, topotecan, toposide, tenipicide, cisplatin, cross-linking agent. Cisplatin is like a platinum analog drug. Can cause nephro, oto, and neurotoxicity. Chloride diuresis, i.e. normal saline, and amifostine can mitigate toxicity. Doxorubicin, adriamycin, intercalated agent plus produces free radicals, can cause dilated cardiomyopathy, high yield. Dextrazoxane mitigates toxicity by mopping up free radicals. Bleomycin induces DNA breaks, causes pulmonary fibrosis. Carmustine or lomustine are alkylating agents. Okay. What about cyclophosphamide? Cyclophosphamide is a guanine N7 alkylating agent. Causes a hemorrhagic cystitis, red urine. Mesna mitigates toxicity by the use of a thiol SH group to mop up acrolein, which is the toxic metabolite for cyclophosphamide that is a toxic for uroepithelium. (5-FU) or 5-fluorouracil, thymidylate synthase inhibitor, prevents conversion of DUMP to DTMP. 6-mercaptopurine or 6-MP inhibits the PRPP aminotransferase enzyme in purine synthesis, requires xanthine oxidase for breakdown. Allopurinol is a xanthine oxidase inhibitor that prevents tumor lysis syndrome in patients receiving a chemotherapy for leukemia. Lysis of leukemic cells releases nucleic acids into the blood, which are converted into uric acid. Since 6-MP requires xanthine oxidase for breakdown, this means that the patient is receiving 6-MP for chemotherapy. Allopurinol cannot be given, otherwise 6-MP toxicity can result. What about azathioprine? Prodrug that is metabolized into 6-mercaptopurine. What about mycophenolate mofetil? Inhibits IMP dehydrogenase, an enzyme in purine synthesis. Can be used for lupus nephritis. What about hydroxyurea? Inhibits the ribonucleotide reductase. USMLE wants you to know that it increases the fetal hemoglobin in sickle cell to decrease the recurrence of painful crises. can be used to reduce the bone marrow cell production in polycythemia vera to reduce hyperviscosity episodes. As discussed earlier, USMLE gives you an acute hyperviscosity syndrome. Choose phlebotomy as the best answer. Hydroxyurea is merely to decrease recurrence. Microtubule drugs. Vincristine, vinblastine, colchicine, griseofulvin, and bendazoles like mebendazole all inhibit microtubule polymerization. Paclitaxel, docetaxel hyperstabilize microtubules, i.e. prevent microtubule disassembly. USMLE can ask for a protein. You ask for the protein these drugs interfere with. The answer should be tubulin. Cells that are quickly dividing, that is to say, GI mucosa, skin, hair follicles, bone marrow, are affected more than slowly dividing cells like myocardium. If the question asks about the levels of which the type of white blood cells are used to monitor for the toxic effects of chemotherapy, the answer is neutrophil, that is to say, agranulocytosis. This is not limited to microtubule inhibitors, but I've seen USMLE ask in relation to these drugs. Vincristine is neurotoxic. Colchicine is used for the acute gout and pericarditis. Griseofulvin is used orally for tinea capitis, patient only, do not give to close contacts. The distinction is asked on the 2CK form. Bebendazole/albendazole are the anti-helminthic agents, mostly for nematodes such as ascariasis, but can also be used for neurocysticercosis. Imatinib, BCR-ABL tyrosine kinase inhibitor used to treat CML, can cause fluid retention or peripheral edema. Erlotinib, EGFR tyrosine kinase inhibitor used for non-small cell lung cancer. Rituximab, CD20 inhibitor on B cells, can elevate the risk of bacterial pneumonia, asked on NBME, which is because the B cells mature into plasma cells, which make immunoglobulins, which are crucial for humoral immunity to fight bacterial infections. And finally, methotrexate, dihydrofolate reductase inhibitor enzyme required in folate pathway, first-line disease-modifying anti-rheumatic drugs, DMARD, in rheumatoid arthritis, first-line oral agent in psoriasis that is non-responsive to topical agents, or for systemic psoriasis arthritis, causes pulmonary fibrosis and mucositis, mouth ulcers due to neutropenia and hepatotoxicity. Toxicity is mitigated with folinic acid, not folic acid, folinic acid, which is aka leucovorin rescue. And that is the end of our chapter for Heme. So we were able to get it done in a single video. Those 20-ish pages. It was, a little bit over an hour and a half. It's like 1 hour, 34 minutes and some seconds. So if you enjoyed that video, smash that like button, hit subscribe. I don't know, Venmo me $100,000, whatever floats your boat in that sense. That's, I guess that's your prerogative. Within reason, But anyways, have a great rest of your day. Thank you, and